Hey everyone, my name is Casey McMillan, and I'm doing my pharmacology drug category project on antipsychotics, mood, and bipolar drugs. So, the best practice guidelines are going to be from the American Psychiatric Association as well as the National Library of Medicine. First line drugs for antipsychotics, specifically for disorders like schizophrenia, are going to be our second generation antipsychotics. And this is just mostly because of the risk of EPS symptoms that we have with the first generation antipsychotics. Research says that that's pretty much the only reason why we usually choose these over first generation antipsychotics, but they're all equally as effective. Examples of these, forgive my pronunciation, are going to be aripiprazole, acinapine, iloperidone, lurasidone, palperidone, quetiapine, risperidone, ziprasidone, olanzapine, brexpiprazole, and cariprazine. So I forgot to mention with the previous slide on our first line drugs that clozapine is also a second generation antipsychotic, but a lot of times it's avoided just because of that risk of agranulocytosis that we're trying to avoid. Our second line drugs for antipsychotics are going to be first generation or typical antipsychotics. Examples of these are going to be the chlorpromazine, fluphenazine, haloperidol, perfenazine, thioridazine, thiothixine, loxapine, melindone, and pimicide. So moving on to our first line drugs for bipolar disorder, usually the mainstays of treatment for manic or mixed episodes are going to be mood stabilizers such as lithium and valproate. And a lot of times they'll add on an atypical antipsychotic such as olanzapine or risperidone. For depressive episodes, usually our first line of treatment is going to be lithium and lamotrigine. So our second line drugs for bipolar disorder, for mixed or manic episodes, a lot of times they'll add an additional first line drug if that initial first line drug wasn't effective, or they'll add carbamazepine or oxcarbazepine instead. And for depressive episodes, in addition to that first line drug that they had already tried, they will add on bupropion, paroxetine, SSRIs, venlafaxine, or MAOIs. So the pharmacodynamics and pharmacokinetics of these drugs that we use. So for SGAs, we're going to block D2 dopamine receptors as well as serotonin receptor antagonist action. For FGAs, we're going to block receptors for dopamine, acetylcholine, histamine, and norepinephrine. For mood stabilizers, they're going to inhibit the inositol uptake process, resulting in inositol depletion. And for antidepressants, they're going to inhibit reuptake of certain neurotransmitters through selective receptors to increase their concentration. Now, these are just some of the effects on body systems that these drugs have. So for SGAs, we're mainly worried about metabolic effects like diabetes, dyslipidemia, weight gain, sedation, and orthostatic hypotension. With the FGAs, like I said before, our main concern are going to be those extrapyramidal symptoms. And they also have cardiovascular effects that we're concerned about. So the EPS that we see most commonly with these drugs are going to be tardive dyskinesia. We also see hypertension and heart failure with these patients that use these drugs. For mood stabilizers, we're worried about CNS, integumentary, and GI system effects. So we see tremors, weight gain, nausea and vomiting, diarrhea, pruritus, rash, headaches, dizziness, vision changes, hypothyroidism, hepatotoxicity, and a lot more. For antidepressants, there are the black box warnings for increased suicidal ideations. So economic factors with bipolar disorder. In 2018, the estimated total annual national economic burden of bipolar disorder and bipolar disorder 1 was more than $195 billion, with approximately 25% attributed to direct medical costs. Drivers of higher direct costs include frequent psychiatric interventions, presence of comorbid medical psychiatric conditions, and both suboptimal medication adherence and clinical management. Indirect costs, including unemployment, loss of productivity for caregivers and patients, accounted for about 72 to 80% of the national economic burden of bipolar disorder and bipolar disorder 1. So economic factors of schizophrenia. The estimated economic burden of schizophrenia in the U.S. in 2019 was $330.6 billion, including $62.3 billion in direct healthcare costs, which is about 19%. $19.7 billion in direct non-healthcare costs, and $251.9 billion in excess indirect costs. The largest drivers of indirect costs were caregiving, premature mortality, and unemployment. So these are precautions for special populations. In children younger than 2, they're at risk for hepatotoxicity and pancreatitis with lithium therapy. Antidepressants may increase risk for suicide, especially when they're just starting out treatment. In pregnancy, neonates exposed to SGAs and FGAs in the 3rd trimester may experience EPSs and withdrawals. Valproate is a teratogen and should not be used in pregnancy. We also want to watch out for lithium use during pregnancy. SSRIs can cause neonatal abstinence syndrome and persistent pulmonary hypertension in the newborn if used late in pregnancy. Now, with lactation, lithium is passed through the breast milk to the infant and may reach concentrations high enough to harm the infant. So breastfeeding is discouraged in use of lithium therapy. For geriatrics, FGAs and SGAs increase mortality when used to treat dementia-related psychosis, and this is a black box warning. And again, this is just brushing the surface of these precautions. There are so many more that are out there. And over the next few slides, you'll see all of my references. Thanks, y'all.